So the questions that we addressed at that point in time were, what was the diagnosis, which was of course a variceal bleed? How would you define a clinically significant bleed? Defining a treatment failure for UGI bleed. What are the risk factors? How do you replace the blood products? What are the
Sir,
caveats?
Vignettes we did not see, sir, because we did not attend the exam itself. So can you please you pass so?
What happened?
We did not see the vignettes, we did not see the case itself.
Today is going to be the debriefing session. So I think
Yes,
you are
sir. Not all of us attended this case, so we did not know about the case itself.
okay.
Only
Okay.
Them here.
So this is John Doe, age 54 years old, male, medical history of chronic alcohol use disorder, liver cirrhosis secondary to hepatitis C, previous episodes of esophageal variceal bleed. The common medications that this patient was on was propranolol, lactulose, and multivitamin injections. You got it till here?
yes, sir.
Yes, okay.
So the presenting complaints were, John presents to the emergency department with severe fatigue, hematemesis, that is, he was vomiting blood, and melena, black tarry stools, which started off earlier that day. He reported feeling dizzy and lightheaded, especially when he was standing. Vital signs included a BP of 88 by 54 mm of mercury, heart rate of 115 beats per minute, temperature of 98.6 degree Fahrenheit. General appearance was this patient looked pale, diaphoretic, and appeared to be in distress. Abdomen was soft, mildly distended, no palpable masses. Patient had a notable hepatomegaly, neurologically alert but slightly confused. So the common questions that come out of this are diagnosis, what is the clinically significant bleeding? How would you define a treatment failure for upper GI bleed? What are the risk factors for bleeding? How do you replace the blood products in an upper GI variceal bleed? Caveats for role of lab tests and fresh frozen plasma use. When do you give antibiotics? What are the pharmacological agents which are used for the same? When and which endoscopic interventions to be used? When would be tips useful in a variceal bleed? So the thing was that this case was discussed with few of the people. And actually, this was supposed to be a debriefing session for them today. I'm aware that there are certain people who had not attended the case vignettes that day. Am I correct?
Yes, sir. Debriefing is for all candidates and uh,
So what I would
to
do
review
is
all.
I will cover these questions simultaneously today. Will that be fine with all of you?
Okay, sir.
Okay.
Yes, okay.
Because for some people, otherwise it will become a repetition. So it won't serve major purpose for them. Okay. So workup revealed hemoglobin of 7.8 grams per deciliter, which was low. Platelet count of 75,000 per microliter, which was again low. INR of 2.1, prolonged, which is consistent with coagulopathy of liver disease, and liver enzymes and bilirubin were elevated. So now when we talk about it, so what is time zero? Time zero is basically time of admission to a medical care facility. Clinically significant bleed would be a transfusion requirement of 2 units or more of blood or more within 24 hours of time zero with a systolic BP of less than 100 mm of mercury, a postural systolic change of more than 20, or a heart rate more than 100 beats per minute at time zero. What is acute variceal bleeding? That is, acute would be defined as time interval from hospital admission, that is time 0 to 120 hours, which is day 5. Treatment failure would be any of the following criteria if they occur within 120 hours, that is, within 5 days of the time 0. fresh hematemesis or more than 100 ml of fresh blood in the NG aspirate, more than 2 hours after start of a specific drug or an endoscopic treatment, hypovolemic shock, a drop in hemoglobin which is more than or equal to 3 gram per deciliter or 30 gram per liter within a 24-hour period. Rebleeding describes clinically significant bleeding which is more than 5 days, that is more than or equal to 120 hours after the first bleed, if that hemostasis was initially achieved. Right? So what are the predictive factors? Which are the ones which are more likely to bleed, so to say? So you've got varices at distal esophagus, stomach, and rectal sites, which are more likely to bleed. This risk of variceal bleeding would actually correlate independently with the diameter of the varix. You have red veil marks, cherry red spots, hematocystic spots, diffuse erythema, which are very characteristic endoscopic signs. Severity of liver disease, which is scored by a child score, along with a history of prior variceal bleed, which are prominent risk factors and predictive factors for a rebleed. Risk factors for early rebleed also include age more than 60 years, a coexisting kidney failure, and ascites. Then you look at variceal pressure, which is categorized as increased, or if you have to signify as a cutoff of what to define as a cutoff in terms of increase or decrease. So cutoff value would be defined as less than or equal to 15.2 millimeters of mercury. Now, when we talk in terms of general treatment principles, you closely monitor the airway, clinical status, vital signs, cardiac rhythm, urine output, and nasogastric output. Maintain this patient as nil by mouth. Keep two large bore IVs ready, preferably 16 or 14 if you can get it. Supplemental oxygen. Here, the goal oxygen saturation is more than or equal to 94% for patients who have got no coexistent COPD. You can give rapid bolus infusions of isotonic crystalloid, 500 to 1000 mils per bolus. Use smaller boluses and lower total volumes for those patients who have got a coexistent compromised cardiac function. When we come to transfusions, what about transfusions? For severe ongoing bleeding, transfuse the blood products in a 1:1:1 ratio of RBCs, plasmas, and platelets. This is same as how it is prescribed for trauma patients. If the patient is hemodynamically unstable, despite crystalloid resuscitation, transfuse 1 to 2 units of RBCs. If you've got a hemoglobin level less than 8 in high-risk patients, such as older adult or a pre-existent coronary artery disease, transfuse 1 packed cell or 1 unit of RBCs and reassess the clinical condition. For hemoglobin less than 7 in low-risk patients, again, transfuse 1 point of RBCs and reassess the clinical condition. Do avoid over-transfusion. Give plasma wherever required for coagulopathy or after you have transfused 4 units of RBCs at least. Give platelets for thrombocytopenia if your platelet counts are less than 50,000. So when we talk in terms of labs, you can get prolongation of PT, INR, and activated partial prothrombin time, which is also referred to as APTT, with mild thrombocytopenia. Sometimes elevated D dimers, especially when the synthetic function of liver is significantly impaired and you get increased portal pressures. Now, keep in mind that all the above tests are very poor at predicting risk of bleeding in chronic liver disease subsets, and they only reflect changes in the procoagulant factor levels. So try to use your PT-INR values as a prognostic measure rather than as a means of bleeding risk assessment. Low fibrinogen levels like thrombocytopenia would actually reflect critical illness and advanced liver disease, which is more prone to bleeding or thrombosis. A lot of talk is done about viscoelastic testing, such as thromboelastography TEG or thromboelastometry, which is ROTEM, but that is mainly used for perioperative transfusion requirements in a liver transplant recipient. Where do you intervene? Do not intervene in the setting of asymptomatic lab change. This could include innocuous ECG, elevations in PT-INR or APTT or thrombocytopenia. Go ahead and give vitamin K to patients who have got suspected vitamin K deficiency. This could be subsets who are poor nutrition, cirrhosis, cholestatic disease, diarrheal illness, or prior antibiotic use. Having said that, this does not alter the bleeding or thrombosis risk per se. Do not administer FFP to correct an asymptomatic or a prolonged PT-INR based on possible risks and costs of this approach, such as transfusion reactions, volume overloads, increased portal pressures, and along with that, a lack of good quality evidence that it provides any clinically important benefit. So who gets antibiotic prophylaxis? Typically, we use a broad spectrum antibiotic such as ceftriaxone, 1 gram IV daily for 7 days, which is initiated before endoscopy. If the patient is getting discharged before 7 days, we switch them over to oral ciprofloxacin. With cirrhosis and GI bleed, prophylactic antibiotics are known to reduce risk of mortality, infections, namely what we are worried about is spontaneous bacterial peritonitis, as well as urinary tract infections and a rebleed. Factors in choice of antibiotics include individual patient characteristics, such as prior history of antibiotic exposure or infection, along with your local patterns of antibiotic resistance. What are the choice of pharmacological agents? Use terlipressin up to 2 to 5 days after cessation of bleeding. Terlipressin has problems in the sense that there are a lot of associations with hyponatremia, and something that you need to monitor is, of course, the sodium levels. Along with that, if the patient is developing an ischemic injury, concurrent terlipressin can be a problem in the sense it aggravates ischemia. You can get more sustained hemodynamic effects by terlipressin vis-a-vis octreotide, and it is actually non-inferior to somatostatin or octreotide. Try to use a continuous dosing, which is actually better. Somatostatin will inhibit glucagon and lead to splanchnic vasoconstriction and decreased portal inflow, whereas octreotide is a long-acting analog of somatostatin. However, its effects on portal pressure are actually of a very short duration. What about endoscopy? Ideally, upper GI endoscopy should be done within 12 hours of presentation. Endoscopic variceal ligation or endoscopic sclerotherapy and esophageal stenting can be done in that same setting. Complications with EVL or endoscopic variceal ligation is lesser band ligation as compared to sclerotherapy. Complications include esophageal ulceration and both esophageal and gastric varices, especially the types 1 and 2, they would be treated by both either sclerotherapy or band ligation. What about balloon tamponade? It is used to achieve short-term hemostasis in those patients who got bleeding esophagogastric varices. At times, esophageal stent placement has been used as an alternative. What you get are 3 types of tubes. One is a Sengstaken Blakemore, which has a 250 cc gastric balloon, esophageal balloon, along with a gastric suction port. Then you have got a Minnesota tube, which has got an esophageal suction port above the esophageal balloon. Then you've got a Linton Naklas tube, single 600 cc gastric balloon. Ideally, a patient should be intubated prior to this procedure, and this balloon can be left in place for 24 to 48 hours. It should be deflated every 12 hours to check if there is any rebleed. When it comes to endoscopic interventions, ligation versus sclerotherapy, that is what may be asked. Ligation is preferred because of lesser rate of complications. However, complications would include an esophageal perforation and portal hypertensive gastropathy. Complications of endoscopy would also include ulceration, bleeding. This sclerotherapy will include ulceration, bleeding, stricture formation, esophageal perforation, mediastinitis, along with worsening of portal hypertensive gastropathy. Then you've got self-expanding metal stands, which are finding their way into routine management for variceal upper GI bleeds now. Do you want to look for any algorithms? Yes. What do you do actually? You do a ligation. If the bleeding is controlled, if there's a high risk of failure or rebleed, yes, then you do early tips within 72 hours, which may be beneficial if there are no contraindications. No, then you continue the vasoactive drugs for 2 to 5 days, initiate or resume non-selective beta blockers once the vasoactive drugs are discontinued. If the bleeding does not get controlled only, and if you've got a continued bleeding or a recurrent bleeding, go ahead and do a rescue tips. If tips can be performed, you perform tips. If it cannot be performed, then again the same cycle follows, that you continue vasoactive drugs for 2 to 5 days, initiate or resume non-selective beta blocker once the vasoactive drugs are discontinued. What is TIPS? TIPS is basically a side-to-side surgical portocaval shunt. Early use of TIPS would be associated with lower all-cause mortality, lower rates of failure to control bleed, and less rebleed. It improves transplantation-free survival in patients who have got advanced cirrhosis. Then you've got contraindications to TIPS, such as heart failure, polycystic liver disease, severe pulmonary hypertension, uncontrolled systemic infection or sepsis, and severe tricuspid agitation. Complications happening because of TIPS will include autosystemic encephalopathy, which can get precipitated. Then you get technical complications such as cardiac arrhythmias and, This would be traversal of the liver capsule. This is more like when you traverse the liver capsule, there can be a bleed and stenosis of the tips. What about shunt surgery? Now, shunt surgery is done, but it's extremely effective in arresting hemorrhage and preventing rebleed. Surgeries can be classified into selective or non-selective or partial, depending on the how the shunt dynamics is there. I'm not going into too much detail into that, probably just a verbal mention. So this is case two. This is 54-year-old man with a long-standing history of alcohol use disorder and a chronic hepatitis C infection. This guy was diagnosed with cirrhosis 2 years ago and has developed progressive liver dysfunction. Recent symptoms include jaundice, fatigue, and abdominal swelling, which have sort of worsened over past 2 months. There have been multiple episodes of ascites which have required paracentesis, and this patient is currently on a low sodium diet along with diuretics. Current problems are this guy presents with complaint of decreased urine output over the past 5 days despite good fluid intake. Patient feels increasingly weak, dizzy, and lightheaded when he is standing. Denies history of chest pain or shortness of breath, but does mention worsening of abdominal discomfort. On examination, he is jaundiced and he is visibly emaciated with prominent ascites and peripheral edema. Blood pressure is 90 by 60 mm mercury. Pulse of 96 beats per minute with mild orthostatic hypertension. When we do a workup, serum creatinine is noticed to be 2.4 milligram per deciliter, and baseline was something like 1 mg per dl 2 months ago. Blood urea nitrogen is 46 milligram per deciliter. Serum sodium is 130. Serum potassium is 4. LFTs were done, which reveal an elevated bilirubin, low albumin, and prolonged INR. There is no significant proteinuria, hematuria, or CAS. Abdominal ultrasound will show an irregularly shrunken liver with no evidence of obstruction, but it will confirm that there is extensive ascites. You do a Doppler ultrasound, which will show patent hepatic and renal vasculature. Can anyone tell me what we would be thinking of with this case vignette? These are all related case vignettes.
Hepatorenal syndrome.
Okay. So questions when we talk in terms of hepatorenal syndrome would be, what are the types of hepatorenal syndrome and how do you diagnose the same? What are the cardinal features? What are the precipitating factors? What about treating hepatorenal syndromes? And is there any role of peritoneovenous shunts? These in broad category would form the various questions of HRS. So when it comes to diagnosis, already we've gone through certain diagnostic criteria. But when we talk about it, here, you look at a patient with advanced hepatic failure. I'll try to. There's a pointer here. So you've got a patient with advanced hepatic failure, portal hypertension, and AKI. You do a clinical evaluation, including microscopic review of urine sediment, and look for any other readily apparent cause of AKI, such as hypotension due to beta blockers or other hypertensive agents, acute tubular necrosis due to shock or nephrotoxic exposure, any acute interstitial nephritis, urinary tract obstruction, etc. If it is present, then you manage the specific etiology for AKI. If it is not present, you look at whether the serum creatinine has doubled or more from baseline. If it is yes, then you discontinue diuretics, beta blockers, other antihypertensive medications, and potentially nephrotoxic agents along and treat the infections if you think that they are present, or if you get a positive screen for infections. In addition, you give IV albumin 1 gram per kg up to 100 grams per day for 2 days. If it is not there, you discontinue diuretics, beta blockers. So this step remains the same. If there is no improvement, give IV albumin 1 gram per kg up to 100 gram per day for 2 days. So now, if there is no improvement, then you get a diagnosis of hepatorenal syndrome. So cardinal features are a progressive rise in serum creatinine. You get an often normal urine sediment. You get a no or minimal proteinuria, less than 500 mg per day. You get a very low sodium excretion, that is urinary sodium concentrations, which are frequently less than 10 milliequivalents per liter. A patient may be oliguric, may not be oliguric, depending on the severity and duration of the disease. So when it comes to defining the types, one is hepatorenal syndrome type 1, acute kidney injury, at least a twofold increase in serum creatinine to a level more than 2.5 milligram per deciliter in less than 2 weeks. Urinary output may be less than 400 to 500 ml per day. Type 2 would be a diuretic resistant ascites, and that is what mainly defines a type 2. Precipitating factors would be an ongoing bacterial infection, a GI bleed, spontaneous bacterial peritonitis, which is more likely in pre-existing renal impairment. Diuretics per se will not cause hepatorenal syndrome, but may lead to azotemia if overzealous fluid removal is targeted. And this is reversible on cessation of therapy. So again, going back to criteria, here, chronic or acute hepatic disease is a prerequisite along with advanced hepatic failure and portal hypertension. AKI here would be defined as an increase in serum creat of 0.3 milligram per deciliter or more within 48 hours, or again, increase from baseline of 50% or more within a week. Absence of any other apparent cause for AKI, and urine RBCs less than 50 cells per high power field when no urinary catheter is in place and protein excretion less than 500. And of course, lack of improvement in kidney function after volume expansion with IV albumin for at least 2 days along with diuretic withdrawal. The common differentials that can come into this would be a kidney injury associated with infection, such as sepsis or spontaneous bacterial peritonitis. You can get a pre-renal AKI. These patients can be having hepatorenal syndrome, which is what we are discussing. And there may be a coexistent parenchymal kidney disease, such as a glomerulonephritis. So what about treatment? You discontinue the antihypertensive agents, including the beta blockers. Use noradrenaline plus albumin with a goal mean arterial pressure rise of 10 mm mercury and albumin for 2 days as IV bolus. You can use IV vasopressin. A combination of terlipressin and albumin is used. Combination of midodrine or octreotide along with albumin is used. If you feel that the patient can be managed in the ward. If all the above fail, then you go for TIPS, or at times certain centers go for CRRT, especially for those patients who have got a serum creatinine which is 1.5 milligram per deciliter despite optimal medical therapy. If the patient is treated with norepinephrine or terlipressin or octreotide, the usual treatment duration therapy is for 2 weeks. So what else can be done? You do a peritoneal venous shunt. It is used in patients with refractory ascites and kidney failure because of hepatorenal syndrome. There's a lack of evidence that peritoneal venous shunting will actually prolong patient survival. There are very high rate of complications, including infection of the shunt. At times, you can use it for chylous ascites, post-liver transplant patients with refractory ascites, and of course, diuretic-resistant ascites who are not candidates for transplantation or TIPS. So this is case vignette 3. Up till now, everything is clear?
Yes, sir.
Okay. So there's the third case vignette and the last one. Basically, a 57-year-old man with a 10-year history of liver cirrhosis secondary to chronic alcohol abuse presents to ED with abdominal pain, fever, and worsening confusion over the past 2 days. His wife says that he has been more lethargic and has a decreased appetite, which is extremely unusual for him. So we give some more data with the case vignette. This patient has got a history of cirrhosis, which was diagnosed 10 years ago, multiple admissions for ascites management, occasional hepatic encephalopathy. He reports diffuse abdominal pain, but is not able to localize it, and it has been worsening progressively. He has new onset fever with chills, confusion, and sort of a disorientation. No history of recent travel, antibiotic use, or surgical procedures. This guy is non-compliant with his medications, which actually include diuretics such as spironolactone and furosemide. So examination findings are a temperature of 101.3 degree Fahrenheit, BP of 100 by 60, heart rate of 110 beats per minute, respiratory rate of 22 beats per minute, 22 breaths per minute, sorry. SpO2 of 94% on room air. This patient appears ill, lethargic, mildly jaundiced. Abdominal distension is there with positive shifting dullness, which indicates ascites. You get a mild tenderness and palpation without rebound or guarding. When you do a neurological exam, this patient is disoriented to time and place with asterisks, and you can get into mild peripheral edema. So we do an initial lab, So we do a CBC in which you get an elevated WBC with a leftward shift. You do LFTs wherein you get elevated AST, ALT, and bilirubin with a decreased albumin. Renal functions, elevated creatinine and serum electrolytes with mild hyponatremia. You do a PT-INR value, which is prolonged, indicating coagulopathy. So anybody can, shoot a guess like as to what we are talking about by now.
Spontaneous bacterial peritonitis.
Correct. So questions that come into this is how to establish a diagnosis of spontaneous bacterial peritonitis. When do you decide to give antibiotics? How do you score for severity and certain specifics? Do you treat for concurrent renal dysfunction or not? And what is culture negative neutrocytic ascites? So diagnosis is established by a positive ascitic fluid bacterial culture and an ascitic fluid polymorph count, which is more than 2 or equal to 250 cells per microliter. Who gets antibiotics? If your patient is having spikes of around more than 100, concurrent abdominal pain, tenderness, altered mental status, along with a polymorph count of more than or equal to 250 cells, then of course these are the patients who get antibiotics. And then you suspect SBP, such as patients with fever, abdominal pain, and altered mental status, as soon as possible. And of course, after you're done with your samples, ascitic fluid, blood, urine, and ascitic fluid has actually been sent for polymorph count. So how do you manage the same? So there's something called as Cliff SOFA score, which is used when it comes to spontaneous bacterial peritonitis. You've got a patient with cirrhosis-related ascites. I'll again try to. So you've got patients with cirrhosis-related ascites and suspected SBP. To perform a diagnostic paracentesis for polymorph count and culture, obtain your blood and urine samples for culture, you determine the severity of illness using something that is called as Cliff SOFA score. Now, do remember why it is important. If your Cliff SOFA score is less than 7, the type of antibiotics you use are of lesser intensity, in the sense that you can use cefotaxime 2 grams IV 8 hourly, or you can use ceftriaxone 2 grams IV once daily. But if your score is more than or equal to 7, your empirical antibiotic becomes a carbapenemide. Then what is ascitic fluid polymorph count? Of course, if it is more than or equal to 250, you give IV albumin 25% solution 1.5 gram per kg once your diagnosis is established. Use ascitic fluid culture results to tailor antibiotic therapy, and discontinue empiric antibiotics unless there is evidence of another infection. You evaluate for other causes, refer to related content if your count is less than 250, right? So how do you treat? Now, majority of these cases are happening because of, wait a minute. Okay. So majority of these cases happen because of E. coli or Klebsiella. At times, they have also documented staphylococcal and streptococcal infection, but majority still is E. coli Klebsiella. For suspected SBP who are not critically ill. So this is a point in contention. You should remember this. Who have got a Cliff SOFA score of less than 7 are typically treated with a third generation cephalosporin. If you've got a Cliff SOFA score of more than or equal to 7, then you use carbapenems as empiric therapy. And of course, empiric antibacterial therapy should be initiated as soon as possible, and once you're done with your samples. So what are the specifics of a Cliff SOFA score? You've got a PEF ratio, you've got a cardiovascular system in terms of amount of vasoactive medication, let's say, to prevent hypertension. You can look up the details specifically later. I'm just covering the broad highlights. Then you look at bilirubin levels and you look at INRs. You grade the hepatic encephalopathy in terms of neurologic system involvement. You look at your serum creatinines, or if the patient is on concurrent use of renal replacement therapy. If there is a concurrent renal dysfunction in spontaneous bacterial peritonitis, it's a major variable which leads to mortality. Risk may be decreased with an infusion of IV 25% albumin solution, which is administered within 6 hours of diagnosis. Albumin infusion should be given if the creatinine is more than 1. That is 88 micromoles per liter and more than 1 milligram per deciliter. The BUN or blood urea nitrogen is more than 30, 10.7 millimoles per liter. The total bilirubin is more than 4 milligram per deciliter. Once renal failure is actually developed, treating with a combination of octreotide and midodrine may be a helpful intervention. So what is culture negative neutrocytic ascites? Most of these patients with culture negative neutrocytic ascites usually have spontaneous bacterial peritonitis. Ascitic fluid polymorph count of more than or equal to 250 cells or microliter who have negative. This is just one person. This is less actually. There's a typo here. This is less who have negative ascitic fluid cultures of culture negative neutrocytic ascites. This is less than, read it as less than or equal to 250. Right. So, wait a minute. Is this visible? Because there will be certain answers that I would like to refer from certain notes that I'd made. Is this visible? This is good enough?
Good, sir.
Yes, sir.
So, all of you, I mean, what drug is this? All of you know this, right? So, this is terlipressin. The common questions that may be asked in this is, what is the mechanism of action? What do you monitor? Do you remember? I mentioned something about terlipressin, about what would you monitor actually routinely for these patients?
Sodium levels.
Correct. And then you look at indications and contraindications for use. Actually, this is a sort of synopsis of what all you have covered already in the slides, right? What about this image? It's basically a site-to-site photocable shunt, there's an image of tips, if you look at it. And we've again covered the indications and contraindications, absolute as well as relative, in our slide sets. So this is again something that may be asked with an image. This is cefotaxime in case if people are not able to pick it up. What would be the indication for use?
Spontaneous bacterial peritonitis.
But which patients?
In cliffs of less than 7 square.
Correct. So this looks easy. Again, what is this tube?
Last question, what is the answer? Cefotaxime.
This is cefotaxime actually. If you remember the algorithm, cefotaxime, 2 gram 8 hourly or ceftriaxone 2 gram IV single dose is preferred for those patients who have got a Cliff SOFA score which is less than or equal to 7. Less than 7, sir.
Okay.
Right?
Yeah.
So, anybody can identify this, I believe. Do you know what this is?
Sangastican, Blackmore.
Yes, absolutely. The Sengstaken Blakemore tube, and indication for use is, of course, to prevent a bleed. What would be the prerequisite for use when you want to use it for a patient?
Is transient, as a bridge for endoscopy to control the bleeding before, uncontrollable bleeding till we have endoscopy.
Correct.
We use
But
it for
you
24 hours to
ideally we
48
need
hours.
to ideally we need to have airway protection in place whenever we are putting it in, right?
Yes.
And what would be the complications that you would be looking at?
Ulceration, perforation, infection.
Of
Esophagus. Aspiration.
Mediastinitis, yeah.
so esophageal rupture is one complication which is extremely important here, right?
Yeah.
Okay. This is simple. You should all be able to answer it.
The picture is not showing very good. Yeah.
Okay, wait a minute. This is fine.
Yes, better.
Encephalopathy.
This is simple. I would expect all of you to be able to answer that. I mean, this is pretty basic.
Hepatoencephalopathy grades.
Yeah, these are hepatic encephalopathy grades. What is the name of that? Can anybody tell me?
Child.
West Havens.
Correct. This is West Haven. Correct. So then you can actually, encephalopathy would be a different thing. I have not covered that vignette here today. But encephalopathy treatment would feature into that. And this is one of the scales that I use to grade hepatic encephalopathy patients. If somebody asks you, asterixis is not seen, so asterixis is less likely in grade 3 and 4. By grade 4, you start getting posturing, decorticate and decerebrate posturing. And if you look at it, guess that is enough. That is enough. Okay. You're able to identify this? Should I make it bigger? This is fine. What happens?
In HRS, it will be more than 20, indicates a pre-renal cause of ARS.
Okay, so what would happen in HRS?
The Bunch
Superior.
ratio will be more than 20.
Correct. The bun creatinine ratio that you get would be higher, right? Okay, I'll again put this up. Anybody can identify the drugs, I guess, right? Are you able to see the drugs?
Yes, sir.
So what are the indications?
Portal hypertension.
And what are the contraindications for a patient of chronic liver disease?
Asthmatic patient.
Hypotension,
Can I have one answer? I believe two people answered simultaneously.
hypotension,
Can you repeat it?
hypotension,
Correct. What else?
Hepatorenal syndrome, bronchial asthma.
Correct. Right. So a patient who is on beta blockers because of portal hypertension, once they develop HRS, then you need to stop the same, right? Okay, what is this?
Both systemic shock.
We've covered this in the slides. I mean, maybe because of the image, you may be getting confused, but we've covered this in the slides.
portovenous shunt,
Correct.
peritoneal.
And where would you use it?
What is the name? Portovenous? Or
No, but where would you use it?
Intractable bleeding or intractable ascites.
Okay, intractable ascites would be your first answer, wherein you should use it. And what are the complications and risks which can be seen with this procedure?
Infection,
the name
obstruction.
is
It
the
can
name is
precipitate
peritoneal.
encephalopathy as well. You get a concurrent rise in portal venous pressures as well. Along with that, at times there can be a small bowel obstruction.
The name, what is the name again?
This is peritoneovenous shunt.
Peritoneal, yes.
CML.
You got it? Okay, these are now, what are these scores used for?
Assess liver failure.
Indication for liver transplantation.
So what would you prefer, MELD or MELD NA?
Well, NA is preferred for transplantation purpose for the
Correct. Nowadays,
for the
MELD NA
transplant.
is given precedence over MELD. And that is how transplant patients are sort of, filtered and assigned. Child book criteria, all of you know, I believe. It's been existing from a very long time. And Cliff SOFA is something that we covered during our lecture today. Right?
Yes.
Child buffer for tips traditionally isn't then used for transplantation.
I didn't get you. Can you repeat? I beg your pardon.
I think child buff traditionally was used as an indication for tips and then used for liver transplantation, but now
No, not
replaced already by
previously,
MELD.
yes. Previously, yes.
Yes,
But now
but
no longer. Now it is all about MELD and MELD NA.
MELD and
Even
MELD,
among MELD
yes.
and MELD NA for transplants, MELD NA is preferred.
What about King's-Bleak criteria?
For acute liver failure only.
That is for mainly acute liver failure. We don't use it for, deciding on liver transplantations. Because liver transplantations, most of time, majority, I mean, for acute liver failures also it is done. But even for those patients now, what we do is a MELD or a MELD NA scoring. Even among both of them, it is MELD NA score which is preferred over MELD.
MELD NA score because of the added sodium? Yeah.
Correct. Okay, this is simple, All of you can answer this. Right?
CRRT
No
measure.
doubt.
Yes, sir.
So where do you use it in chronic liver disease?
Hepatorenal syndrome.
Hepatorenal syndrome.
Where else?
As a
Do
bridge
you
to
use it to alleviate
liver
cerebral
cancer.
edema for patients of grade 3, grade 4 encephalopathy?
Yeah, hyperammonia, yes.
And where else? Prior to preparing patients for transplantation.
Yes.
This is the last one, Again, this is something that all of you should be able to answer.
Endoscopy.
Band ligation.
Correct. This is endoscopic
Band ligation.
manipulation. And what you see in the image A is actually a varix. Yeah. So this is the varix and this is the band that you can see blue colored. Right?
Yes, sir.
Okay. So that is finished. Would you like to cover anything else in this? I thought I covered too much in this small session, partly because some of you had not attended my initial session of the case reports.
So if this real done in a mock exam, so you can pass through the vignettes or questions asked. But if it is as a lecture, no, well and good. It's very informative and very nice. But if there is vignettes and yani step by step questions, we can go through.
Well, I believe already, I think they have my PPT with them. So I will ask them if they can share it with you.
Thanks.
Doctor, any imaging come for liver in exam, like ultrasound or CT scan?
You can get liver abscesses. You can get something like what I showed you, a TIPS image. You can get a peritoneal venous shunt image. All those things may be there. It may not be essentially this classical, but yes, you should be able to, find out. You should be able to, sort of delineate it, and you should be able to tell about it.
Thank you.
And of course, I didn't cover an image of esophageal stent. Esophageal stent has just started coming into work now. Not widely used and definitely not practiced at all the centers.
Here, where is the place of this retrograde splenic vein obstruction, balloon obstruction? What's called?
Retrograde?
Splenic vein balloon obliteration.
I'm not aware of that. I've never done that, and I'll have to read up a little bit about it. This is new for me. Retrograde?
Balloon obstruction of splenic vein. I think what's called.
Basically, TIPS does something similar wherein you do a balloon obstruction. So
They are going through renal vein, then to by interventional radiology through splenic vein. Then they will go to the make a balloon obstruction. I forgot the name.
balloon obstruction is typically done by TIPS only.
Okay.
Right? So this is all for today. You're all fine with this?
Yeah, that's okay.
Okay.